I think both my earlier speaker have covered many points. What about the stone? And that's where is laser has a place in the stone. The contribution of laser may be more by miniaturization of instrumentation, which will be made possible than by any advantage it may have as a fragmenter. That was what Graham Watson and Stephen Dettler he opined in '87, and we had a machine, pulse dye laser, in 1989, and we did use it for some time, but coumarin dye was very costly, and we had to give it up. But then after a few years, now we have 10-watt laser, 20-watt laser, 30-watt laser for a stone, and of course we have a high power laser like Luminous, a 100-watt laser, and they all has been used. What has happened after the laser has come is the instrument size has decreased from 11.5 to 6 French ureteroscope. Now even a 4.5 French ureteroscope is available in children. And again, of course, the flexible ureteroscopy, the small nephroscope, the small pediatric ureteroscope, and the rigid ureteroscopes are available. Another thing is the laser fibers which you need, and you can use 550 or 940 micron fibers for in a larger instrument, but what you require is a 272 or maybe 365 micron fibers for a flexible instruments. And these are the life of this fibers is quite good, and you can use it after re-sterilization again and again. Now the mechanism of lithotripsy is manifold. Either it's a chirping, coring, drilling, or a snowstorming. Okay. So this is the different way it is been used in breaking the stone. Well, in the laser fiber has a mechanism of action by forming a plasma which creates a miniaturization of shock, and it breaks the stone. You had to bring the laser fiber very near, and here you can see that you can use it by just bringing it near to the stone, but making sure that it doesn't retract into the endoscope, otherwise it will break the telescope. And this is the acoustic shock waves. I will go a little faster. The advantage of the laser compared to the other energy is a minimal up migration, minimal tissue damage, ability to fragment the stone regardless of composition or size, ability to deliver the higher energy setting even though the smallest of the deliver fibers. And disadvantage, of course, as Maheshwari, as Pankaj has said, is the initial high cost of the device and the cost of the laser fibers. Now this is the what you can do is you can combine the low energy, low rate to the very high energy, and you can break the stone even with a small fiber like this, which can go through the instrument. And here you can go right up to the 52 or even 100, even if you are using a calcium oxalate monohydrate stone in a gone situation. Now ureteroscopy is the ideal situation where you use a laser because you don't want upward migration, and here you can disintegrate the stone into such a small fibers that either they will pass or you can remove it. You have to learn a little technique so the stone does not migrate above. And here you can see that stone is fragmenting. Once the stone fragments, you can bring that fragment, you can bring the laser fiber down and then fragment those stones in the small particle till you fragment the stone completely. And of course, with the availability of the flexible ureteroscope, you can started using it in a kidney also. This is a 54-year-old lady with a high morbidity, and we didn't want to do a PCNL in this patient. The stone was in the pelvis, and here is this is the, of course, 26-year-old male with the right renal pelvis, and we just wanted to see whether we can break the stone in this situation. And here we use a sheath, and then we use a flexible scope which will go through that. So with the flexible, the sheath will, electric sheath will keep the pressure low because the time taken is more. And here you can see that the stone is visualized, and slowly you can disintegrate the stone till it becomes as dust. And then you can, once it becomes a dust, then you can chase the stone fiber in each calyx and then clear the stone. It takes little time, so you have to make sure that the pressure in the pelvis remains low. You can use a hand pump to wash those fragments away, and once they migrate to the one of the calyx, you can break into a very small fragment which will be passed. Now, very often you have a small stone in a diverticulum, and here you can use a scope and then flexible scope, and you can go inside and then have a look. And here it does two advantages. Once you see the small opening into the here you can see the small opening here of the diverticulum, which you confirm on the fluoroscopy, and then you can divide it, the mouth of that diverticulum, by using the little higher energy. And once it is cut, then you can see the stone inside, and then here you are enlarging the mouth of the diverticulum, and once you have broken those thin tissue of that mouth, and then you can go and break the stone completely till it is clear. So it can use where you can divide the mouth as a tissue, as well as you can break the stone. Now here is a large stone in a diverticulum in the upper calyx, and here you can of course do a PCNL, but being in the upper pole, sometimes it is associated with higher morbidity if you do a PCNL. And here you can do is again like the previous one, you can go. Being in the upper calyx, it is easier to use a larger fiber, and then you open up the mouth of the calyx and then visualize the stone, and then you can go. So here you have a situation, the size of the stone it doesn't make difference if you are expert, like say Michael Grasso, and he has used 52 cases in a Stegon calculus. He used a monotherapy of a flexible electroscopy with laser in a multiple sitting and cleared the stone. And here you can see that you can localize that stone into that upper calyx nicely, and you can go on fragmenting till it is completely clear. Now you have a lower calisal stone which is quite large, where you will have a difficulty of doing the flexible electroscopy. You can do a minipur, where a small the amplas like 16 French, and you use a 14 French nephroscope, and then you can visualize the stone, and you can see that stone. Initially you can use the energy which is a little higher, 35 power, and then you reduce the energy as the stone is fragmented into a smaller particle, and here you can manipulate with the energy and you break the stone, and you can judge that density of the stone by the way it breaks inside. And once you have completely cleared, you can take it out, and this is the stone fragment. Sometimes you have a large stone like this, and you can this is the recently I used last week in a Stegon calculus, but here you can see that here you are using a, can you click on this? You can break that larger stone very fast if you use a very high energy and clear the stone. And here you can see that by using a higher energy, even a large stone Stegon calculus, you can manage with a PCNL. So you can, the best advantage that it can use even in a pediatric patient, this is the patient with a bladder stone, and here you can use a small, yes, you can pass, it's okay, you pass into the bladder, you visualize the stone, and it pass a small fiber where you can break the stone. This is the stone, and the stone can be broken, and you can avoid the surgery. I think everybody has seen this. I'm just going ahead. There are some complications associated with this, that if you touch the tissue, especially in the kidney papillae, it can bleed. And once it starts bleeding, then the visions becomes obscured, and then do it. This is the stone which was picked up in the lower calyx and taken to the upper calyx, and we started breaking, and at the same time that it touched the tissue and it started bleeding, then the vision become obscured, and then it become difficult to visualize the stone completely, and then you cannot break it. So you have to be careful that when you are using, make sure that you don't touch the tissue. And sometimes you can divide that soft tissue, especially in the ureter, and then you can perforate that ureter, and which is happened in this case, where we were trying to catch the stone and then break the stone using laser, and here we have made a small perforation, and then of course you have to put a DG and take it out, but you have to be careful that it doesn't happen. So it is like this young 7-month baby with a lower ureteric stone, which and there was a upper kidney stone. Upper kidney stone we did a ESWL, and then after breaking the stone in the lower ureter, and what happened is that while doing that, we broke that nitinol fiber into the ureter. We left it at the moment. When we went back to remove the DJ, we just removed the broken nitinol basket from the ureter. So you have to be careful. Now lastly, the miniaturization has helped us to devise a small optical needle. This is the optical needle of 16 gauge. It has a 3-part needle, and it can be used with the 8 French sheath and obturator. This is the 2 devices which we use. This is a small flexible fiber optic telescope which can bend, and you can pass through this needle, and this is the irrigation, and we can puncture this, and I puncture it through the ultrasound guidance, and under vision you can see the needle going through the tissue. And once it is inside, you put this the attachment where you can pass a flexible telescope. You can use a laser fiber to the middle, and this is for the irrigation, and from that needle you can bring it. What I call is a micro PCNL. This is the first time, happy to tell you that we have done it about in 18-19 cases, and this is the one demonstration where we have punctured the kidney. You can see that once you puncture, you will be able to visualize the stone. Once we have visualized the stone, we have removed it and put a 3-part attachment, and then we pass the telescope again through that needle, and then adjust the telescope, and here you can see the stone. You pass a laser fiber, and through the needle we are breaking the stone. So what Steve Dettler said 20 years ago, that it has helped, the laser will help to disintegrate the stone through a smallest possible instrument, and this is the a small needle where we are passing the laser fiber and breaking the stone completely. If the stone is a little larger or a little bigger in the pelvis, we can just pass a guide wire and dilate the 8 French dilator, and then use that. And then at the end of the procedure, you just take out the needle. So that's what you call a micro PCNL. I'm very happy to tell you that the paper has been accepted in the Journal of Urology, and this is a trial which we are doing it, and then there need to be lots of, this is still experimental, needs lots of modification, but advantage of laser is that you can do it. So the caution, of course, used near the guide wire or a basket is necessary if it is used in ureteroscopy. Laser fiber should extend at least 2 mm beyond the tip of the endoscope to avoid destroying the lens system or working channel of the endoscope. And laser is nothing but a power play. This is, I don't own the machine, but I was happy to use it for a few days. Thank you.